Good morning or good afternoon, depending on where you are based. On behalf of the World Health Organization, Regional Office for Europe, welcome to this technical briefing for the European Health Report 2024. It is great to see so many of you with us today. My name is David Novillo, and I am the Regional Advisor for Data, Evidence and Digital Health at the World Health Organization, the Regional Office for Europe, based in Copenhagen. And it is my pleasure to welcome you today. So before continuing with the technical briefing, I would like to make some housekeeping announcements. First of all, if you have not done so, we will appreciate if you could please identify yourself in the participant list with your full name. You can do this going to the participant list and clicking on your name. Then you will see the option Rename. That will facilitate the discussion during this session. This session will last 1 hour and can be followed in English and Russian. As you can see at the bottom of your Zoom screen, you can choose the language in which you would like to follow this meeting. Furthermore, at the top of your screen, under the option Overview, you can choose the language in which you would like to see the presentation that is projected. In addition, we would like to inform you that this session is being recorded and will be publicly available afterwards. Moving to the content of this session, the European Health Report is a flagship publication of WHO Regional Office for Europe that is published once every 3 years. The reports provide a comprehensive overview of the health status of the people in our region to guide strategic priority setting. Today, we are launching the 2024 edition of the European Health Report, which is called Keeping Health High on the Agenda. To mark this occasion, we are organizing this briefing for our member states and partners to inform you about the main findings from the report and open the floor for questions. So, I'm handing over to Dr. Natasha Sopardi-Muscat, now Director for the Division of Country Health Policy and Systems in our office, who will present the main findings from the report. This presentation will take around 15 to 20 minutes, and after that, we will open the floor for questions and comments. So with that, I'm not taking more time. Please, Natasha, the floor is yours. Thank you so much.
Good afternoon, good morning, good evening to everyone who has made the time to join us online. Thank you very much. Also to my colleagues, Marika and Stefania, who are here with me in the room. And in the next 10 minutes or so, we will take you through the key highlights of this European Health Report. So can we kick off, please? In 2024, for the first time, there were more people aged over 65 than under 15 years old in the European region. And the projections show that there will be 3 times more people aged 80 plus in the next couple of years. So let me just pause here because I see that some people are asking for to be able to view also slides in English. I'm not sure, David, if we have a technical hitch.
Links needs to go to the top, and then there will be an option that is English presentation. So then you can pick up the Russian slide, the English slides.
Okay, could we have the next slide, please? And the next one, please. Thank you. So, as a starting point, what we know is that there is a 10-year gap between life expectancy and healthy life expectancy in our region. And this gap is actually larger for women because women live longer than men, but they live more years of life in disability. And on top of that, next slide, please, we have currently over 14 million in our region living with dementia. And this is a number that is set to almost double over the next 5 years. Can we have the next slide? Yes, thank you. The sad news is that nearly 50% of older people with severe self-care difficulties currently do not get the help they need for personal care or household activities. So as we can see, the gap between living longer and living healthier is set to increase unless we take actions to help people live healthier for longer and to provide the necessary support for those older persons who need it. And how can we do this? Let's go to the next slide. It starts from children, from childhood. And what do we see across the European region? That even in this area, key indicators are stagnating or deteriorating. We go to the next slide. We know that every year, 76,000 children are dying before their 5th birthday. But what is even more important is to understand that there is a 21-fold difference between the best performing member states and those that are lagging behind. Of course, this is not acceptable, and there is work to be done. And most of these deaths are associated with preterm mortality, for example, birth associated incidents, as well then as lower respiratory tract infections and neonatal sepsis. But moving on, we also know, we can have the next slide, that our young people are facing new and evolving threats. And up to a quarter of young people across the region are using e-cigarettes. This is a trend that risks undermining decades of progress on tobacco control, because e-cigarette use among young people now surpasses traditional cigarette smoking in many countries. But also we know that 1 in 3 children is overweight, 1 in 8 children is living with obesity. But childhood obesity is not only negatively impacting children, but it sets the stage for a lifetime of increased illness, be it from cardiovascular disease, diabetes, and other chronic conditions. But threats to children's health, and we are putting children's health right at the top of the agenda, since we are working at the moment to renew our strategy for the health of children and adolescents, together with the support from UNICEF. We hope to take this forward to the next regional committee. But what we see is that the threats to the health of our children aren't just physical, they are also mental. Growing dangers, increasingly associated with the digital world, particularly cyberbullying, but also exposure to marketing of harmful products. So if we go to the next slide, we know that girls' mental well-being is generally worse than boys. We see this consistently across a number of reports from our series on health behavior in school children. We see that social media, online harassment, and digital dependency are increasingly affecting young people's well-being, although it is not all young people who experience problematic online gambling or problematic digital social media use. We see that this is affecting a part of our population, and it's also associated, for example, with less sleep. So we are producing an updated evidence brief, because we know that the topic of how best to address, to make our children and young people safer in what is increasingly an online world is a key priority for many countries. And over here, we need to also understand that girls are scoring lower mental well-being, lower life satisfaction. We see a decreasing trend across the region over the past years, but it's affecting girls even more, because girls score 50 on the well-being scale, with boys scoring 62, and this is a scale out of 100. So it is really quite low. Moving to the next slide, let me just pause for a moment. As many of our member states know, one of the special initiatives being put forward for consideration under the forthcoming European Programme of Work by our Regional Director, Dr. Hans Kluge, is tackling violence against women and girls. And we know that girls face a higher risk of harm and mistreatment, and in fact, more than 1 in 4 women and girls experience violence in their lifetime. And here there is work to be done, because the health sector is often one of the first ports of call. We need to be able to train and build the capacity for health workers to recognize the signs and to be supported to refer appropriately, as well as tackling upstream factors which could be shaping this trend. Moving now to suicide, let me start by saying that the positive news is that we have seen in many countries a decline in mortality by suicide. Having said that, men are 4 times more affected than women, and it is the leading cause of death in the age group 15 to 29 years. Moving to another topic now, vaccine preventable diseases. And here it is very sobering to see that in 2023 alone, we saw 58,000 cases of measles, 87,000 cases of pertussis, and people may say, okay, but what is the baseline? This is a huge increase over what we are used to seeing in our region. These diseases should be behind us, and yet they are making a comeback due to declining vaccination rates, often fueled by a combination of misinformation and in some cases also still with gaps in good access to vaccination coverage. So when we look at where we stand in terms of vaccination coverage, only 7 member states across the region, and you can see this on the next slide, have achieved greater than 95% coverage for diphtheria, tetanus, and pertussis vaccine. And then when it comes to measles-containing vaccine second dose, to the pneumococcal conjugate vaccine, we see that the rates are even lower. We see, for example, that a low coverage rate of 62% was experienced in some member states when we are talking about the measles vaccine. So the picture is one of stagnation, and the picture is also unequal between countries, unequal within countries. Let's not forget that immunization remains one of the most cost-effective and life-saving interventions, and neglecting it is simply not an option if we want to retain the progress that we have seen over past decades in health and health indicators across the European region. Meanwhile, moving to another topic, antimicrobial resistance, this remains a critical threat to global health. And in the European Health Report itself, you will see that only about 60% are using access antibiotics, for example. But also when we talk about tackling infectious diseases such as tuberculosis, HIV, and hepatitis C, despite a 25% reduction in the incidence of tuberculosis and a 32% decrease in deaths, drug-resistant tuberculosis remains a challenge. And indeed, just about 2 or 3 weeks ago, we actually convened a meeting here at the regional office in Copenhagen, because we also know that access to effective TB drugs remains a challenge. And we know that there is new evidence that shows that access to the shortened 9-month treatment plan for multi-drug resistant TB can achieve a treatment success rate of 83%, surpassing the current average of under 60%. So there are tools and technologies that are available, but we also need to ensure that they are accessible to those who need them. Let's move to another topic now. Non-communicable diseases. It causes 9 out of every 10 deaths in the region, but 1 in 6 people in the region, and more men than women, when we look at this statistic, die before the age of 70 from 4 major non-communicable diseases. The bulk of this is actually due to cardiovascular disease and cancer deaths, with a smaller amount of deaths being attributed to diabetes and chronic respiratory diseases. Indeed, cardiovascular disease, a large amount of which is preventable and treatable, remains the top killer, especially in Eastern Europe and Central Asia. Cancer then is close behind. And what we see with cancer, because 5-year mortality rates are also improving, but incidence continues to rise, is that this is exerting a greater burden on health systems in the western part of our region. And talking about cancer, for example, we know that more can be done to prevent this. And moving to the next slide, the beauty when we talk about NCDs, and there will be the high-level meeting in New York in September this year, is that we know what can be done to prevent them. Let me remind you of WHO's best bias evidence, and I know that Gordon and his team are also working on a quick bias package of measures to be issued later this year. But coming back to risk factors, of course, genetics and aging plays a part, and there isn't anything much we can do to stop that, aging at least, for sure. But there is much that can be done when it comes to lifestyle. The European region is home to the heaviest drinkers in the world, with adults averaging almost 9 liters of pure alcohol intake per year. And 1/4 of people in our region are still daily tobacco users. Now, here we have seen a decline in tobacco use, but again, since 2015, the rate of decline has lessened. And so it's possible that we will become the top tobacco users globally unless we can do something to once again come back on track with tackling tobacco use and pushing for a reduction in tobacco use. Coming now to obesity, the truth is that 1 out of every 4 adults across our region is obese. Again, you will see that there is quite a large variation across the region, with some countries doing better than others. Let me remind you that the target over here was to halt the rate of increase, and 2 countries, at least in our region, France and Spain, have successfully done that. So let's continue to focus our efforts. Also, we know that there is work that can be done in terms of food reformulation also to tackle obesity. And now, what I would like to come to is climate change. People living with non-communicable diseases are more likely to suffer the effects of climate change. The impact of climate change on health is becoming increasingly evident. We had over 61,000 heat-related deaths in 2022 alone. And we know that environmental and societal shifts are in turn placing a heavier burden also on health systems. So moving now to health systems, you don't need me to tell you, sitting in your member states, that health systems are under pressure. And we know that health systems have to transform to meet the changing health needs. Let's unpack this a bit more. Let's come to the next slide where we can talk about workforce. Never has the European region had such a high number of health professionals. When we look at the data we have available for doctors and nurses, we see that countries have taken steps to increase the number of doctors and nurses in our region. So why the shortage? The shortage is, first and foremost, different countries have different densities of doctors and nurses. Secondly, the distribution. We know that in many countries, rural areas and primary healthcare is particularly under pressure, and we have seen the ratio of GPs to specialists decline. But we also know that some countries are facing out-migration of their health workers. Others are seeing workers moving to the private sector. And of course, our reports clearly show that the health workforce is aging. 30% of doctors in Europe are over 55 years old, and the number of countries have more than 40% of their doctors being aged 55 or older. As health systems struggle to cope, one of the outcomes is that we see an increase in out-of-pocket expenditures as people seek recourse also to parallel systems. And over here, our data shows that more people are struggling to access and afford the care they need. Out-of-pocket payments, for example, for medicines in primary care, particularly for low-income groups, burden families and push us further away from our goal of universal health coverage. And sadly, up to 1 in 5 households in our region, in some countries, have to make the choice between paying for healthcare or paying for housing, heating, or other basic needs, what we call catastrophic expenditure. As you can imagine, this is particularly concentrated in the lowest income quintile. And finally, coming to the end of our presentation, let me underline that our health systems are far from sufficiently prepared for current and future health emergencies. And this is a question that we are often asked. The European Health Report now provides the evidence with which we can answer, which is that the average capacity score for implementing the international health regulations has remained practically unchanged at around 73%. In some domains, there are higher scores, and in other domains, such as risk communication, essential health services provision, there remains work to do, as well as on the legal and policy aspect. So, I guess my take-home message is that at the moment, a lot of our countries are also laser-focused on security. But a key part of guaranteeing security for our citizens is also linked to health security. And as you are aware, in the coming days, we will also host a hearing on health security, which has been identified as one of the key topics in the forthcoming European Programme of Work. But to close, I would say that this European Health Report does indicate that there are some areas where we have made gains, not fast enough and not sustained enough. But there are other areas where we are stagnating or falling behind. We should not take decades of progress for granted, and we need to find ways also to deal with new health challenges that are facing our population. We are able to say this because we have the privilege of being able to collect and analyze good quality data that is provided by many member states who are joining also on this briefing. And let me express my gratitude for your trust in WHO to be a custodian of your data and to be able to use this data in a transparent manner to help you advocate for health in your countries, for investment in health in your countries. And my plea, therefore, is to continue to ensure that we share data in a comprehensive, timely, and good quality manner, because without the ability to track and disseminate this data, we cannot monitor the impact of our actions. We navigate in the dark, and we cannot hold ourselves, our countries, our leaders accountable for the health of our populations. Thank you, and I hand back with this to David.
Thank you so much, Natasha, for this great presentation. So now is the time for the discussion and for any comments or questions that you may have. If you would like to participate in the discussion, please raise your hand with the function in Zoom, or share your comment in the chat. So to help minimize back.
Stop sharing, David. I think we can stop sharing this.
Yes. Super. Thank you so much. So we will open the comments for questions. Also, I would like to alert that we have several colleagues from WHO technical units that have been actively contributing to this activity. So please, colleagues, if there is a question that is related to you and you would like to complement or just to respond, please also take the floor so I can identify you in the chat in the participant list, because it's going to be difficult to find you. So please, if there is any question related to your area work, just raise your hand so I can identify you quickly, and then I can pass the floor to you. So I am opening now the floor for comments or questions, and I can see Chuf, Professor Wolfgang, followed by Rolf Detlef 3D. And I will appreciate if you could please introduce yourself before doing the question. Professor Wolfgang, please go ahead. And you are mute. So
now it's okay. Can you hear me now?
yes.
Wolfgang Gebel, I'm professor of psychiatry from Germany. One of the questions is, does the non-communicable diseases include mental disorders? I mean, the high rates of early deaths certainly also accounts to them, but has that been analyzed separately, especially those data which Natasha gave us about the deaths before the age of 70? I mean, mental disorders, people often do have comorbidity of heart or lung or other kinds of conditions, medical conditions. So the question is, have they been separately analyzed, or do you know about those data?
Thank you so much, Professor Wolfgang. I can see that Dr. Godin Galea, that is the director for the special initiative on NCDs and innovation, is connected. Dr. Galea, I don't know if you can hear us. I can see you online, but I don't know if you are.
I am.
Yes, thank you so much, Godin. Please go ahead.
Short answer is yes. We are increasingly tending to report on mental health issues separately than non-communicable diseases, because there is a large burden of morbidity and impairment of quality of life that comes from mental disorders. But generally, when we analyze the premature mortality, we report the four major diseases, and then there is another category where we include also the smaller number of deaths that are ascribed to mental disorders.
Thank you so much, Dr. Galea. So following the participant list, I can see Rolf Detlef 3D. I hope that I pronounced properly. Please go ahead.
Yes, thank you very much. I'm also from Germany, professor of neurophysiology. I'm involved with the International Association for the Study of Pain and with the Federation of Scientific Societies in Germany. My question is similar to my colleagues. It's about morbidity load from non-communicable diseases that are not part of the big four mortality risk. And my addition is musculoskeletal health and chronic pain. If you take depression and musculoskeletal health and chronic pain, each of them dwarfs all the four major causes of mortality with respect to the morbidity load. And I think it would be very timely to include the morbidity load in your reporting so that you don't only report mortality. And I had a second comment in the chat. When you report the risk of climate change, yes, indeed, there are premature deaths from climate change, but I think this is again dwarfed by the increase in morbidity load by, for example, increase in frailty, deterioration of all the other NCDs. And when we talk about NCDs there, you have to expand beyond the big four. So mental health and musculoskeletal health are important, but there are also some organ diseases like liver diseases, kidney diseases that are not listed in the big four. And the third question is then, will Europe try to get the list of NCDs expanded at the high-level meeting at the United Nations in September in New York? Thank you.
Thank you so much. So with your permission, I will go back again to Dr. Galea for questions 1 and 3. And then I would like to invite Dr. Aciopi, that is connected. Francesca, I know that you are connected. We are just taking the opportunity that our main experts are connected today to pass the questions that are related to them. So the second question will be directed to you after Dr. Galea. Thank you.
I'm trying to keep my answer brief here, but a number of very important issues have been raised in this last intervention. I will be very personal. 5 years ago, I was undergoing chemotherapy for severe pain. For severe cancer with associated a lot of bone metastases and a lot of pain. And I told myself that if ever I recover from this and if ever I am in a position of authority, I will do my best to look at the alleviation of pain and to make a difference if we can. And indeed, we are doing that work together with Natasha's division. Our cancer program, for example, is funding or largely funding a palliative care position within the health systems area. And we really value that collaboration where palliation, pain relief is extremely important. And we have huge problems in our region where I will just name one problem, that in some countries the barriers to even giving pain relief during the type of condition that I experienced has so many legal barriers that there is a very strong a large number of people in Europe who do not enjoy the benefits of such relief. And that, of course, then is completely different than the problem of chronic pain, such as musculoskeletal disorders. There's a large series of rare diseases, each of which is extremely infrequent. But when you add them up, there are 6 to 10% of the European population suffering from them. It is impossible, and of course then the major organ problems, liver, kidney, that burden. Given the current conditions of funding within the work of WHO, we have two constraints. One, the target that we are asked to work for is one on premature mortality, so that highlights the top 4. But maybe more importantly, it is now time to start considering alongside those top 4 an approach, and we talk about this internally inside WHO, about what is multimorbidity and how to bring it in to our work on health systems and how to bring it in to our work on non-communicable diseases. We can't have a separate program on fatty liver, a separate program on cystic fibrosis, a separate program on psoriasis, a separate program. The resources are just not there. Not to say that Europe does not have big issues with all of these. But I think if we find a way of connecting these disorders in a common approach on multimorbidity alongside not losing the emphasis on the main 4 killers, where we still have a long way to go before we reach our targets, I think that might be the way of the future.
Thank you so much, Juan. It's much appreciated. And for the next question, I can see that Francesca is connected and Oliver too. So I don't know who would like to take the second question.
Yes, and since good morning, everybody. Thanks for the questions. And since we have with us Oliver, who is particularly specializing in this area, I think it would be the best answer would come from him. And happy to chip in.
Excellent. Thank you, Francesca. Oliver, please go ahead.
Okay. Hello, everyone. Yes, on the question on heat, I think 3 short messages. The first one, the 62,000 that was shown on the slide by Natasha is likely to be a significant underestimate, as it is only based on published numbers and estimates that refer to about 30 countries across the European region. And we know very little about the additional burden that we see in terms of mortality. Your comment on morbidity, I couldn't agree more, and I have not much to add. The suffering and the suffering that comes along with increased heat and the chronic effects that are being accelerated by excessive heat play a major role. But again, we have problems to quantify these numbers in a very precise way, and therefore we are, in terms of communication, more often than once using mortality numbers and not referring to morbidity. But this is simply due to the gap of data that we have. And the third message is complementary to your question, basically, that we are currently working on an update of WHO's guidance, global guidance on heat health action planning. So that is also providing member states and stakeholders with support in how to prepare for and to prepare and respond to accelerated heat. Over to you, David.
Oliver and Francesca. So I'm going to pass the floor to Ricardo Moschetti. And before doing that, please, if there are any other comments or questions, please remember you raise your hand or put your comment in the chat, okay? Ricardo, please go ahead.
Thank you, David. Thank you. Thank you for the presentation and for the WHO team to take the time to present us the report. My name is Ricardo Moschetti. I'm working as a senior policy officer at the European Cancer Organization, a federation representing member societies and healthcare professionals most active in oncology, as the name could refer to. As a non-state actor at the WHO Europe area, we really greatly supporting this kind of initiatives and activities in replying to feedback and consultation. And I think one of the main areas, perhaps that's my main question, would be how WHO Europe is envisioning to create any synergies that can be developed in different areas, from taking the example of the cases of cancer, which in Europe and in the EU especially have been developed in the last couple of 4 or 5 years with the Eurosplitting Cancer Plan, and what envisioning activities and initiatives can be done at the level of WHO Europe to not reinvent the wheel in terms of risk factors and public policies on prevention that we've seen in the slides as well. And for the majority of NCDs area, I would say so, as that could also fit for diabetes and others. Thank you.
Ricardo. So as one big portion of the report is about NCDs, we are not surprised that there is an important debate around this, right? So then we are going back to you. Thank you so much.
Thank you so much, Ricardo, for the question. And indeed, we are seeing in Europe, as the report very well shows, a slight increase overall in incidence in cancer and a slight reduction in mortality. And as we find that health systems become more able to detect and treat and help people to survive, but at the same time, we still suffer from the behavioral, occupational, environmental risks that we have exposed to ourselves in the past, and the incidence will still keep rising. And we still have yet to see how much of a rise there will be in the countries of the east of the region, where there is quite a lot of currently quite a lot of cardiovascular mortality, but as that declines, cancer will start to rear its head and we will see a lot more cancer. In brief, there's a wide range of work that we are doing. On the prevention side, I would focus on our intense focus on tobacco, and most recently on alcohol. We are sometimes a lone voice in raising the issue that alcohol is a cause of cancer, and still we would hope that civil society like yourself can help us to expand and disseminate that knowledge further. Within the early detection, we think that in Europe there is quite a lot of maybe overemphasis on screening, not enough on early detection. There's a lot of lives that can be saved by appropriate early detection. and there's a lot of commercial interest in promoting screening that may be expensive and as yet unproven as yielding enough benefit. Within the treatment side, there's a lot left to be done. We have looked, for example, at the type of chemotherapeutic agents that are used in populations, and we find that in one country, for example, up to 40% of the chemotherapeutic agents that were used are agents that are novel but have little or no impact on the survival. So there's a lot of possibility of looking at how we are planning our packages of treatment and where we can shift to reduce waste and improve effectiveness. And there's a lot, we've already mentioned the issue of palliation. There's a lot to be done in areas of pain relief and survivorship support. Quite apart from two special programs, one on cervical cancer elimination, where we are pursuing the global agenda, the global targets for eliminating cervical cancer is the only cancer at this stage that we can even think of eliminating, and a special focus on childhood cancer. That gives you a very rapid overview, and there is space for civil society collaboration in all of those points.
Much, Odin. And we have two more requests, one from Professor Ilona Kickbutt, with whom we would like to take the opportunity to thank for being one of the external reviewers. So, Professor Kickbutt, please, over to you.
Thank you
You're
very
on
much.
mute. There we go. Yeah, perfect. Thank you.
Thank you very much for this overview. I was, of course, very happy to see that the report included such an important issue, such as violence against women. And I would really like to commend WHO on that. I understand that the regional director has also made that one of his priorities in his present term of office. And of course, it's linked to so many other health consequences that arise from that violence. So I was wondering if you could say a little bit more about how the regional office is going to take this further, because it is really such an important new dimension that has now emerged from a WHO report of an increasingly difficult issue. Thank you very much.
And with this, I'm going to hand over to Natasha, also mentioning that Isabel Jordi, our colleague Isabel Jordi, is connected. Thank you. Natasha, over to you.
Thank you, David, and thank you, Ilona. And indeed, this is a special initiative that is being put forward because we are very, very concerned also about the factors that are leading to some new and very worrying trends. Having said that, when we look at the data available, the data is actually quite old, uneven, and we know that this is a difficult area to investigate. So we have come up with an internal list of objectives that we would like to take forward. Of course, this all needs to be very much taken in the scope at the moment of the ongoing reprioritization exercises that have been driven by the executive board and that are taking place within the context of the global program of work, and this impacts also the European program of work. But nonetheless, we are committed within the resource constraints that we have to try to update the evidence and see how we can build capacity for action within the health sector in our region. And David, did you say that Isabel is connected? Perhaps Isabel can share a few more details, although it's still very much work in progress, because of course it will depend on the elaboration of the European program of work, which is currently being consulted with member states.
I don't know, Isabel, if you are, I can see that you're connected. I don't know if you could please take the floor.
Yes,
Yes,
thank
thank
you,
you.
David and Natasha, and thank you, Ilona, for your question. And yes, following on Natasha, actually WHO will be producing the new estimates this year, and we are planning to do a deep dive on the European data on those estimates. But we are also planning to do a deep dive on the policy implementation, because what we see is that even though Europe has a lot of policies, multi-sectorial policies to address such a problem as violence against women and girls, the health sector is a little bit behind on taking that role on what it is our own responsibility and how do we contribute to multi-sectorial policies. So next week on the 8th of March, actually, we will be launching this special initiative of the European Regional Office on Violence Against Women and Girls. And we are planning to, on the one hand, to foster that high-level commitment among ministers of health and the health sector, while we combine it with more technical products, including the review of the evidence, the review of the policy implementation, but also what are the compendium of good practices and how do we address these new forms of violence, like can be that are technology facilitated violence, or even some worrying trends that we are seeing of new forms of tolerance on violence among young populations at levels we had not seen before. So thank you for that, and there will be more coming on this new initiative.
So much, Isabel. So we're going to pass for the last question again to Professor Wolfgang. Please go ahead.
Can you hear me now? Yes.
Yes.
Well, in addition to what we heard by Natasha, the overall picture around Europe or European countries, the question is there a gradient from low to high morbidity or mortality across the different countries from east to west or from north to south, which may be related to socioeconomic or any other determinants which may play a role here? Thank you.
Much for your comment. So with this, I cannot see any other requests for taking the floor. So I think that with this, we could start concluding this briefing. And before doing that, I would like to draw your attention to the fact that next to the main report, a short highlights brochure is available on the WHO website in English, French, German, and Russian in our 4 official languages. And also the currently main report is only available in English, but also will be a Russian version will be available very soon on our website. And with this, I would like to pass the floor to our divisional director, Dr. Supardi Muscat, for the closing remarks. Thank you.
Thank you, David. And just to reflect on Professor Wolfgang's question too, as you leaf through the report, what you will see is that there are some gaps, of course, where there is still a gap between the eastern part of the region and the western part of the region. Notably, for example, when we look at under 5 childhood mortality, when we look at cardiovascular diseases. But in some other trends, then when we look, for example, at tobacco, smoking, when we look at the use of alcohol, when we look even sometimes at some indices of well-being in children, a far more mixed picture emerges. So as I was telling the regional director this morning, there is homework for every single member state in the region to do, and every single country can learn from someone else. And this is the beauty of pulling such a report together. You can't sort of take a straight line and say, you know, the level of economic development necessarily is going to affect all indicators. It's a more mixed picture. Of course, political decisions on universal health coverage make a difference. We know that where the proportion of public spending as a proportion of total spending on healthcare is high, then you tend to get less catastrophic and impoverishing health expenditure, for example. We know that where the level of economic development, the level of protection for women and girls is higher, again, you can see certain outcomes. And then there are certain cultural differences that come in too when it comes to risk behaviors. In some parts of the region, we see a very, very similar level of risk between men and women adopting similar risk-taking behaviors. In other countries, you might see a different pattern emerging, for example, when it comes to tobacco smoking for men and for women. So there's a lot to unpack. Please keep your questions coming. Please keep telling us how we can improve this type of product. And to close, allow me to thank, first of all, David, Marike, Stefania, Tyrone, and all the members of our data and digital team who have been carrying out a huge lift, together with colleagues who have worked closely with us as co-authors, Marie Del Nord, Elsa Negro-Kaldic, and Damir Ivankovic. You have seen Gordon representing one of the other technical divisions, but allow me to thank Francesca and Oliver representing the other technical division. Allow me to thank all the colleagues in our technical units. We are merely pulling together the reports on the different technical areas with the inputs of the colleagues. But it's not only the technical colleagues. Allow me also to make a special mention to our publications team, who have worked really hard to meet our deadlines and our requests for making changes and tweaks until the very end, and our communications team, who have also advised us and worked closely with us to ensure that the message is as clear as possible. I would like to thank our editors, designers, and translators, who again have worked to very tight deadlines, and our external reviewers. You have heard Ilona, Professor Ilona Kickbush, take the floor, but allow me to thank also Professor Mika Gisler and Professor Martin McKee. We have had the support of our regional director, who, as he said at the opening of the press conference for journalists today, WHO is going through a challenging time, but today we are launching a report that shows what WHO does when it does its best work. Provide impartial evidence in a politically neutral manner to allow countries, academia, and non-state actors to use this for advocacy, for investment in health and well-being. Thank you for joining us. Have a good afternoon and evening.
Thank you so much, colleagues, for connecting today. Good afternoon to all. Thank you.